Welcome everyone to the Vein Nevada virtual seminar on venous disease. This is Molly Canaday, Director of Integrated Marketing for Vein Nevada. We're excited to have all of you join us this evening and thankful to have this opportunity to share updates in vein healthcare. During tonight's virtual event, you'll hear an educational presentation on vein conditions and associated symptoms such as varicose veins, achy legs, restless legs, swollen legs, leg discoloration, and leg ulcers. Attendees of tonight's seminar may also request a free vein screening to help identify if you should see a vein specialist. We'll have time at the end of Dr. Ahmad's presentation for question and answer, so please submit your questions through the Q&A box. Without further delay, I'll introduce you to Dr. Waqaar Ahmad. Dr. Ahmad is a vein specialized interventional radiologist at Vein Nevada. He's fellowship trained in vascular and interventional radiology with ABMS board certification in diagnostic radiology by the American Board of Radiology. Dr. Ahmad is experienced in minimally invasive venous treatments, including radiofrequency ablation or closure fast, phlebectomy, and VenaSeal closure. Before relocating to Northern Nevada, Dr. Ahmad served as an interventional radiologist at both outpatient facilities and level 1 trauma centers in Scottsdale, Arizona. Welcome, Dr. Ahmad, and thank you.
All right. Well, thank you very much, Molly, for that lovely introduction. I'd like to thank everyone listening in today and attending today for their attention to talk about venous disease. It's something that, I'm certainly passionate about, something that's important to discuss, something that's not talked about very often, and something that we need to address. And I'm glad all of you have joined us today for this evening session to talk about venous disease. My name is Dr. Waqaar Ahmad. I'm here based in the South Reno office in Reno, Nevada at Vein Nevada Clinics. Up there, you can also see the director, Dr. Franciosa. He's actually based in Henderson, Las Vegas, where he runs a clinic there. So as I mentioned, these were our two office locations, one in South Reno. This is the one that you guys will mostly see. We're on Double R Boulevard in Professional Circle. So please welcome and come join us and check out our office. So let's talk about vein disease. How common is vein disease? It's about 2 times more common than coronary artery disease. You hear a lot about heart disease. It's actually much more common than that. It's even 5 times more common than peripheral arterial disease. About 40% of Americans are actually, about 40% of Americans actually have chronic venous disease. We can see here, even compared to stroke or cardiac arrhythmias, heart disease, heart valvular disease, the incidence and prevalence in the United States is much higher of venous disease. So it's important to talk about. It will progress if it is left untreated. As I mentioned, 40% of the population has chronic venous disease, but only 1.7 million seek treatment. If you think of the US population, almost 400 million people, that's almost 150 to 200 million people that have chronic venous disease. So it's something that is something that definitely needs to be addressed. Here we can see, some of the markers of chronic venous disease. You can see people have varicose veins here. People have the skin changes, the discoloration. You might notice this in the general population when you're walking around. You see people with these types of legs all the time. So, that's definitely a marker of chronic venous disease, and it will continue to get worse with time. How does it arise? There is a genetic component, autosomal dominant inheritance with variable penetrance. What that means is that if someone in your family has chronic venous disease, if they have varicose veins, if they have those legs that you just saw, more than likely, it is going to be passed down through the generations. It is higher incidence amongst women than men. So, it's just more common amongst women, although there are plenty of men who are also affected with chronic venous disease. Some of the risk factors, obesity, lower levels of physical activity, high blood pressure, older age at menopause, just kind of a sedentary lifestyle, smoking as well. All of these contribute to the development of chronic venous disease. So we can start by talking through the venous anatomy. there are two major sets of veins in your legs. Here in the light blue, in the blue, you can see the superficial venous system. These are your surface veins. You have the great saphenous vein and the small saphenous vein here in the back of the calf. These are what we treat here. In addition, you have the deep system as well. That's in the purple. That's the femoral vein, the popliteal vein, and the tibial veins. That is deep inside next to your bones. It's actually surrounded by your muscles. And what happens is you have these perforator veins, which kind of connect, they're tunnels that connect the superficial and the deep system. And so by treating the surface veins, the superficial system, the blood actually gets rerouted. It can go through these perforator veins into your deep system and will get pumped up normally. And we're going to talk a little bit more about the pathophysiology and how this actually happens. So the deep veins are usually not the source of the skin changes, the symptoms, the pain, the ulcerations, all the things that people notice about their legs. The deep veins are important. You might have heard the term deep venous thrombosis. So a lot of blood clots and stuff can happen in the deep system. But really what we deal with here is the superficial venous system. The superficial venous system actually only does about 10% of the work of the venous return of your leg, but it's responsible for more than 90% of the problems. The deep system does about 90% of the work, but it's usually not problematic. And as we mentioned, the superficial system, that's going to be responsible for all those skin changes, the ulcerations, the edema or the swelling, pain, cramping, itching, heaviness, achiness. So all of those things are basically related to the superficial venous system, which is what we treat. So this is kind of a diagram of how veins work. The job of the veins is to bring the blood from the feet and the toes back up to your heart, right? The arteries bring the blood down to your feet from your heart. The veins bring it back up. And your veins, they have these valves inside of them every few centimeters. So what happens is the blood starts at your feet down here, gets pumped up to your heart, and then the valve closes, and that will prevent the blood from falling back down. So it's supposed to be a one-way system going up. But what happens over time with some of the genetic factors we talked about, the valves, they don't meet anymore. They stretch out and they no longer close, and that blood is now flowing back and forth. It's going in the wrong direction. And that's what leads to, what we call venous hypertension. It leads to the extravasation or basically the migration of the proteins and the blood cells in your blood into the tissues of your leg, which results in a chronic inflammatory state. And then, eventually you'll get to a venous ulcer. And we'll go through some of these stages in the next couple of slides. Just a word, we talked about the treating the superficial system. The deep system is actually surrounded, we can go back here. The deep system is actually surrounded by muscle, and what happens is every time you move your leg, the muscle will contract, and that contraction of that muscle will actually press on the vein, and that will help pump up that blood through your deep system. Now, your superficial system does not have that assistance of the muscle pump. So what happens is when the valves fail in the superficial system, in these surface veins, they don't have that muscle pump assistance. So basically, treatment is the only option to prevent the progression of venous disease. So what are the symptoms of chronic venous disease? People can get aching, they can get fatigue or heaviness in their legs. They can get pain, throbbing, burning, even a stabbing type pain. These are all symptoms of venous disease. Leg cramping is a big one. People wake up at night with these intense leg cramps, and a lot of that can be related to bad veins. Swelling is very common, what we call edema, just leg swelling. The skin can become itchy as well. And restless legs is a big one. About 60% of restless legs can be attributed to bad veins or chronic venous disease. So we see a lot of patients, with just restless legs. They'll come in, we'll see that their veins are leaking through the valves, and then we'll treat their veins, and then their restless legs will improve or get better, or basically be cured of that. And then numbness as well can be a symptom of chronic venous disease. So what are we looking on physical exam when we take a look at your legs? Some of the things we're looking at for is telangiectasias, reticular veins, varicose veins, lower leg dermatitis, cellulitis, hyperpigmentation, edema, and ulcers. So let's go through some of these and take a look at what they are. Um, Telangiectasias, these are basically your spider veins, very common in the population. You'll probably notice a lot of people get these, especially as they age. Half of people that have these spider veins will complain of discomfort or pain. And, most people will get relief after the treatment. And it's actually an underlying sign of a more extensive venous disease. These are reticular veins, okay? These are basically these enlarged kind of green-blue veins under the skin. They're usually associated with spider veins as well. They can be symptomatic. Some people can get kind of achiness because what they can happen is when the veins leak from above, these veins fill up and they engorge with blood. And that venous hypertension can result in achiness and discomfort. So that's also a sign which you may notice. Varicose veins are, a big sign of venous disease. They're commonly seen along the middle, the kind of the inside of your thigh and calf. And it's actually a significant marker, but only about half of people with vein disease have varicose veins. Varicose veins are actually a good sign because usually what happens is when your body senses that hypertension in your veins, all that high blood pressure that's there from all that pooling of blood, it will create varicose veins to divert that blood pressure. So it's actually a good sign. But people who don't have varicose veins, they're going to start getting the other symptoms, that dermatitis, the red flaky skin, because their blood isn't being diverted through these different channels. So they're actually going to end up with a little bit more severe disease. But either way, it's all a sign of chronic venous insufficiency, and they can be treated. About 20% of people who have these varicose veins will end up with ulceration, so it is important to get these treated. As I mentioned, the other half of vein disease, these are the skin changes. These commonly happen in people who don't have varicose veins to divert that blood pressure. So they'll just have constant high pressure in their veins, which will cause these skin changes to occur. They're often on the insides of the lower leg and the ankle, and it can result in, recurrent cellulitis or infection of the leg because it's so brittle, fragile, kind of flaky skin. And it is a high predictor of future ulceration. What happens is basically the blood is pooling in the lower legs, and because it's pooling there, the iron and the proteins in the blood kind of leach out into the skin and the soft tissues and stain the skin like a tattoo. Now, once it gets to the stage, it's essentially permanent. It's like a tattoo, but we can lighten it up a little bit with treatment of the veins, and it can basically, it will prevent the progression of this. Otherwise, it will keep continuing to creep up the entire leg. So we can prevent that from happening. So regarding the progression of vein disease, a lot of people kind of start out with these spider veins in their ankles. That's called corona phlegmatica. It is a marker of chronic vein disease, and it's usually one of the first signs that people see. Eventually, it will progress into that hyperpigmentation stage where you get the discoloration of the ankles and the calves because of the iron that's staining the blood. Because that iron irritates the skin, it results in what we call venous eczema. And what it does is basically a form of dermatitis where your skin is constantly inflamed due to all those proteins and inflammatory markers that are leaching out into the skin from the blood. Eventually, that skin will scar down, and then you'll get lipodermatosclerosis or fibrosis, okay? And this is just basically a result of the chronic inflammation that's happening in the skin due to the chronic leaking of the veins. Eventually, you'll get this what we call atrophy blanche, or this is a pre-ulcerative state. You can see here that, there's almost like a lesion that's about to form. And eventually what will happen is that you will get an ulcer that does not heal. And that results in significant, problems for people. But even, we treat people at all stages of vein disease. And it definitely helps them. Even in coming in at the ulceration stage, it's not too late. We still improve the lives of these people. Edema, this is a big one. A lot of people have leg swelling. Venous insufficiency is a common cause of that. There's obviously several other causes of leg swelling. It can be related to cardiac or heart issues, it can be related to liver problems or kidney issues. But one of the big ones that's often overlooked is veins. So it is important to get it looked at. This is one of the end stages of vein disease, venous ulcers. You might see people with these. Often they'll have to go to wound care specialists, every week or two to get these dressed and debrided. It can be really painful. It can be really annoying to deal with. It's embarrassing. People don't want to walk around with these types of legs. And what we notice is that a majority of these ulcers are actually cured when we treat the veins that are leaking and supplying these ulcers. So when should you consider treatment for venous disease? Basically, anytime you're having symptoms, anytime there's aching, any pain in the legs, any leg swelling, that's unresponsive to conservative measures. And we're going to talk a little bit about what those conservative measures are. Anyone with restless legs, this is kind of something that's new in the literature. A lot of people don't know that restless legs can be attributed to vein disease, but that's definitely, something to consider getting treated for. People that are unable to tolerate compression, you can go to your doctor, your primary care doctor, with a lot of, you may have varicose veins that are aching. They may start you on leg compression stockings or compression socks. A lot of people can't tolerate that. Compression stocks are something you'd have to wear every day for the rest of your life to kind of prevent the progression of vein disease. So if you don't want to do that, then definitely consider getting them treated. Any of those skin changes we talked about, any signs of active or impending ulceration, or if there's any active bleeding from the veins. Because the veins that form when they're constantly leaking are really weak. They have weak, fragile walls, so they can start basically spontaneously bleeding. So that's a bad marker that should get treated. So what do we do when we suspect vein disease? There's a whole process, where we work you up. It starts with a detailed ultrasound and conservative therapy, and then eventually we'll get to the procedure state. The conservative therapy is something, we start you on your first visit. Most insurances require that we do at least 3 months of conservative therapy before they will pay for the procedures. So if you're considering getting your veins done, just know that, there's basically a 3-month waiting period in which you have to try the conservative therapy with the stockings, and try these different things before we're able to do the procedures. So for conservative therapy, exercise is always good, at least 30 minutes of being active per day. As I mentioned before, the deep veins are surrounded by your muscle. So every time you move your legs and are active, that muscle contracts and helps pump up that blood and prevents that blood from pooling down. Leg elevation is also excellent, especially for people who have leg swelling or achy, throbbing veins at the end of the day. You just lift up your leg and help that blood drain and basically counteracts the effects of gravity, because gravity will push that blood down. So you want to counteract that with elevating your legs, especially at the end of the day when you're relaxing or watching TV or resting in bed. People find that, pain medication like ibuprofen or Tylenol may help, especially if they're having a lot of pain. Some people find that warm or cold, compresses or soaks may be beneficial as well. So those are some things that the people can try. And of course, the mainstay of the treatment is compression stockings. So compression stockings are good. They actually help improve the venous outflow. They increase the velocity of the blood flow as well. So they kind of ramp up your veins, and then they improve the overall circulation. They reduce the risk of blood clots. They can help people reduce their symptoms of aching, fatigue, pain, swelling, all of these things. When people present, the first thing we're going to do is put them on these compression stockings, and they usually do help. They're also important for the treatment of venous ulcers. It's one of the mainstays of treatment, basically because they don't allow the blood to pool down there, and they kind of squeeze the foot and the leg and force that vein to pump up that blood back into the heart. They are useful. However, there are a lot of disadvantages to compression stockings. Often patients don't tolerate them too well. They can be uncomfortable. They're really difficult to put on and take off, especially elderly patients who have a lot of arthritis or have a lot of back pain. Bending down and putting these on can be difficult. They do require a lot of effort to get on and get off as well. And the symptomatic relief is usually only limited and temporary. Again, they're only going to work if you're wearing them every day, basically for the rest of your life. So it is important basically to get treated if that's something that most people can't do. In the summertime, it's really hot. People don't want to walk around in shorts wearing these compression stockings. So they're definitely have their disadvantages. So after the conservative therapy, we do the detailed ultrasound. We'll scan all the veins in your legs, and we're going to make a map of the veins in your legs, see which ones are leaking, which ones are big, which ones are dilated, and see all the valves that are leaking. And then we're going to come up with a plan for your treatment. So how do we treat the veins? As I mentioned, the surface veins are what we treat, and we treat them by shutting them down. And by shutting down the surface veins, we prevent that blood from leaking back down into the foot and make sure it's only going the right way. By shutting those veins down, the blood goes through the perforator veins into your deep system and gets pumped up normally, because the deep system does 90% of the work of the leg anyway, and it's more than happy to take over 100% after we treat your veins. So there's a couple of main ways we can treat it and shut down the vein. One of the veins is what we call radio frequency ablation. Okay, this is basically using a heat technology, and by using heat, it essentially cauterizes the vein from the inside. Okay, we use what we call a tumescent anesthesia. That's where we surround that vein with fluid so you don't feel any burn during the procedure. Small puncture site about the size of a grain of rice. We're not opening you up or making large incisions. And usually we only do 1 week of compression stockings afterwards. With the glue, there's another way, which is called the VenaSeal closure system, and this is basically glue. It's medical grade super glue, and this is injected into the vein, and it basically seals that vein shut using a medical grade super glue. This one actually doesn't require that tumescent anesthesia that I mentioned before, where we have to surround the whole vein with fluid. So the VenaSeal, the glue system, is a little bit easier for the patient. You only get kind of one poke and one, pinch and burn down below. There's no risk of any thermal injury with this one because we're not heating up your tissues. You don't have to wear compression stockings afterwards. Okay. So those are some of the main differences we use, and most people get to pick which one that they want to do. So the thermal ablation, this is where what we do is we make a small puncture site at the bottom of your vein. We thread the catheter up. This is the catheter. It's like a long wire with a heating element attached to it. We thread that up all the way to the top of the vein, and then we basically numb up the whole length of the vein. So with this radio frequency ablation catheter, most people feel about 4 or 5 pinches going down the length of the vein, and that's all you should really feel during the procedure. After everything is numb, we just start the burn and we cauterize that vein all the way through its length. The procedure takes about 30 minutes to do. Everything we do here is under local anesthesia. We don't give any general anesthesia or sedation. You don't really need it. You'll be awake during the procedure. And the good thing with that is that there's less complications. Most of the complications from surgery arise from the anesthesia. So from here, here we don't do any of that. So you can drive here, drive home, and you can resume your normal activities immediately. And that's the beauty of getting it done. It's really good at closing the vein. About 95% remain closed after 1 year, as well as 5 years. And the heating, we can do it with radio frequency or laser. They're both basically equivalent. So here's kind of a diagram of how that works. We, make a tiny incision, thread that catheter up the vein. Then it has a heating element inside of it, this probe here. And what it does is it basically just heats up and collapses that vein. So it cauterizes it. And then all we do is pull back a little bit and heat up that next segment. And we do that the rest of the whole vein. After the procedure is done, we encourage walking. We need basically a minimum of 30 minutes of walking after the procedure. You can return to your normal activities immediately afterwards. The only thing with the radiofrequency ablation is that you do have to wear compression stockings, which we will give you. You're gonna have to wear those for 1 week after the procedure. And about a week after the procedure, we rescan the legs to make sure everything was treated adequately. With the VenaSeal closure system, this is the other way to close the vein. This uses a medical grade super glue, an adhesive. And what we do is basically we thread this catheter up the entire vein. Now this time I don't have to numb up the whole vein because nothing is being burned. So you're not gonna feel any burning or anything like that. You're not gonna, this one only has one site of anesthesia, so just one pinch instead of 5 or 6. And all we do is basically pull the catheter back and start gluing the vein. Here's a diagram of that. Here's basically your vein, and you can see the catheter inside the vein, and it's delivering the glue, and it delivers that, you know, kind of 1 centimeter ahead of the catheter, and then the vein super glues shut. And with that one, again, you know, you don't have to wear any compression stockings afterwards. So this is a great choice, especially for elderly people who can't tolerate the compression stockings, and for people who want a little bit less pokes. Now with the VenaSeal, the glue, you have to remember you are going to have medical grade super glue in your body forever. So that is a medical grade implant that's going to be inside of your body. So that is one thing to consider with VenaSeal. With the radiofrequency ablation, all we're using is heat, nothing is left in your body. As well, another thing that, you know, we can do for the varicose veins, especially if there are large varicose veins, what we usually do is we can physically remove them, and that procedure is called a phlebectomy. So what happens is you'll see, you know, large squiggly varicose vein bulging out. I'll numb up the skin over that. I'll make a tiny incision, take a small hook, and basically just scoop it out. Okay, and we do that throughout the length of the varicose vein. And it's kind of done the same way. You're awake during the procedure. Most people feel a little bit of pulling and tugging during the procedure, but they do pretty well afterwards. Here you can see a picture of a varicose vein that I removed. And you can see this is what the vein looks like. It's actually, you know, bigger inside of your body when it's filled with blood, but when it's decompressed and empty, this is what it looks like. Here's some of the results of that. You know, usually what we'll do is we'll treat the underlying surface vein that's filling this up, either with the radiofrequency ablation or the VenaSeal glue, and then we will physically remove this with a phlebectomy. And here you can see what the leg looks like afterwards. It's definitely much better, and it looks normal. Here's another great result. You can see these legs with long, large varicose veins that are completely gone after the treatment. Here you can see some people with chronic venous disease. You know, here's that venous stasis dermatitis. Those red, flaky, irritated looking legs that basically almost heal completely. And this is just after 1 month of treatment, after 1 month after the treatment. So they will continue to improve, and basically they're going to go back down to normal. More pictures here. You can see 6 weeks after the treatment. This gentleman had pretty bad chronic venous disease with really bad venous stasis dermatitis and flaky, irritated legs and feet, which are much, much better after 6 weeks of treatment. Another thing that can be done is the cosmetic treatment of telangiectasias. A lot of people are interested in this. You know, a lot of people have spider veins. The important thing with this is that it's important to get the underlying vein treated first. So, you know, the surface veins that we treat here, they're the ones that are leaking and causing these spider veins to appear. So what happens, and what we usually do, is we'll treat those underlying leaky veins first, and then these can be injected later on, okay? And that's basically what the way to treat that is what we call sclerotherapy. It is considered a cosmetic procedure. And what happens is a small needle is inserted into this spider vein, and a medicine, usually polidocanol or something similar like saline, can be injected into the vein, and that will basically shut that down as well. All right, so that's kind of our overview on chronic venous disease. I'd like to thank you all again for joining us, and I hope that kind of answered some of your questions, and as well kind of talked about why it's so important to get chronic venous disease treated, because if left untreated, it will progress, it will get worse, and we can really improve some lives by getting it treated. All right, and now we're going to open it up to any questions. All right, thank you.